A very good afternoon, everyone. It's my pleasure to welcome you to the FOGSI JOGI web series Clinical Pearls of JOGI episode 4. We've had 3 great episodes till now, and today we have the fourth one. We would like to begin our episode with Saraswati Vandana. Maria, it isn't audible. Can you play again?
नमो नमः ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनी नमो नमः हंसवाहिनी नमो नमः ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनी नमो नमः
I now call upon our editor-in-chief, Dr. Madhuri Patel, madam, to give her welcome address.
Can you hear me?
Yes, ma'am.
Yeah, okay. You can go ahead.
Doctor, can I have a slide, Maria? Dr. Madhuri Patel, madam, she is the Secretary General FOGSI. She's the Editor-in-Chief, Journal of Obstetrics and Gynecology, India. Madam has been the Joint Secretary FOGSI 2009. She's honorary consultant at various hospitals. Welcome, madam. I request you to now give your welcome address.
Some of the other, my video is not getting connected. So can you hear me? Can all of you hear me? Okay.
Yes, ma'am.
Respected our President, Dr. Jaideep Chand, then our chief guest, Dr. Rishikesh Pai, with whom I had a great time when I was secretary and he's a president. We did a lots of work during his period, and it was a very, very vibrant year. Of course, Dr. Shanta Kumari's and now Dr. Jaideep's year are also going well. But, we had many yatras during his tenure and we did lots of work, and he's really dear friend to me since last, 3 decades. And our guest of honor, Dr. Adi Dastu sir, he is my mentor along with Professor C.N. Purandare, and he is always there to guide me. Our today's chairperson are Dr. Sujata Dalvi. She's associate editor of our journal. Second step after me, Dr. Alka Pandey, Dr. Kiran May. These are our national coordinators, the national editors of our JOGI. And of course, the speakers are Dr. Vandana Bansal, Dr. Poonam Yadav, Dr. Pragna Supe, MOCs, Dr. Pragna Changle, and Dr. Sunil Tambewarkar. I cannot forget my, other editorial board team, along with Dr. C.N. Purandare, Dr. Adi Dasu, Dr. Suvarna Khadilkar, Dr. Geeta Valsarkar, and of course, we have our editorial team, another people, Dr. Arun Nayak, Dr. Anayata Chauhan, Dr. Ashwini Balerao Gandhi, Dr. Pragna Changade, and secretary team, Dr. Pragna Supe and Sunil Tambewarkar. Our national coordinator, corresponding editors are Dr. Sushil Chawla, Dr. Radhika, Dr. Kiran Mai, Dr. Shobha Guri, Dr. Dipti Gupta, Dr. Mala Srivastav, Dr. Alka Pandey, Dr. Madhva Prasad, Dr. Sampat Kumari, Dr. Ashok Kumar, Dr. Ramni Devi, Dr. Subhash Chandra, Dr. Nidhi Group, and all my reviewers and dear friends who all have logged in. As we are aware now, this is our web series we have started since my tenure from January 2024. And this is a clinical pulse of JOGI. And this is held every third Wednesday of the month between 4 to 6 p.m. Before I talk about the clinical pulse of JOGI, I would also like to mention that our JOGI is academic wing of FOGSI, and we have bi-monthly issue which is on digital platform as well as the printed form. And this printed form is distributed to all our 43,000 members free of cost, thinking that many of the people do not have internet connection or many of have not digital savvy, so at least they can read, implement, policies, and our patient can be benefited. And every time when we release the journal, the new issue comes, we send the SMS to all our members, and it is open, all the papers along with the abstract and full text, it is open for 15 days. And then when you want to access it, you can go to our JOGI website or FOGSI website and access by putting your phone number or your email ID or membership number, and you can access all the article. So now, let me talk about this clinical pulse of JOGI. It was conceptualized when I was in America. My son-in-law over there is editor your team and elsewhere, and he said, "Okay, mommy, we should start this clinical pulse of Jogi." And we, really felt that it is a very good initiative where our authors are involved. Many times our authors, they don't get a platform, and when they are presenting their work in a conference, hardly few people are there. So we felt this Jogi is a good platform to give them the good platform which they can tell the research work. Of course, the Jogi is also our, it is going to 43,000 members plus other internationally. So that is also good platform. But our own people, if they can present on this Jogi platform, it is very good. So today is the 4th episode. We have taken the best paper, award-winning paper, and Dr. Vandana Bansal is also having a award-winning paper on her topic, what you call as prenatal invasive testing at a tertiary referral center in India, a report of 433 cases under a single operator. And I know Vandana because we are there together, and I know how much she is committed to the herself, not only herself, but the patient and everybody and the resident. And then second paper is our Zestosis score. That is very, very important because after PPH, even though we have reduced the maternal mortality rate to 97 per 100,000 live birth, we are also marching towards the sustainable development goal of 2030 MMR less than 70 per 100,000 live birth. But let me tell you, after PIH is the second most common cause of maternal mortality. So this Gestosis score, who is going to present, Dr. Meeta Gupta or Dr. Poonam Yadav, this is also a very good paper which we have selected, and we'll know that how to prevent or how to counsel all the women and the relative about developing PIH, and if we can do preventive measure, this can really reduce the burden of maternal mortality and morbidity. With this, I am not taking more time. I thank you very much for logging in, and we want that this program should go on. We have last 3 episodes, we had good interactive section with the authors because we asked author why you selected this topic, how you went about, what was the study design, and it was really very interactive section we had. And with this, our juniors can take home message, or they can do studies for themselves by picking up this same paper also. So I'm wishing both our speakers all the best, and thank you for joining. And thank you, Rishikesh, Adidasu sir, and my whole editorial team. Thank you for joining, and all my delegates and reviewers. So Pragna, you can go ahead.
Yes. So, welcome everyone to the 4th episode of Clinical Pulse of Jogi. Let me introduce the chief guest for today. We have 2 chief guests, Dr. Jaideep Chan sir and Dr. Rishikesh Pai sir. Dr. Jaideep Chan sir is the president of FOGSI. He is the chair of IGJ committee. AOFOG is the project lead FOGSI for USAID projects. He has been the secretary general of FOGSI. He has been awarded the FRCOG honoria causa by the RCOG. He's been the past president of MOGS. And he's a consultant in Ashwinity at Maternity and Surgical Hospital at Ghatkopar. And he has been the immediate past deputy secretary of AOFOG. Sir has been the chair of various committees. He has been instrumental in drafting a proposal for FICO for a grant of $13 million. And he is working with MOGS for underprivileged women for menstrual hygiene needs. So he has contributed a lot to FOGSI, be it statement on cesarean section, hysterectomy rate, contraceptive implants, ART bill, surrogacy bill. Sir is a little held up in a meeting, so he will join us in a while. Let me introduce the next chief guest for today, Dr. Rishikesh Pai, sir. So thank you so much for accepting our invitation and being here. Sir has been the president of FOGSI. We know that he had a fabulous year in which lot of yatras were conducted, anemia correction projects were taken. He's the founder and medical director of Bloom IVF and chief administrator of FOGSI Manyata project. And he has liaison with FIGO Cancer, Women's Cancer Committee, editor of the Indian edition of British Journal of OBGY. We all know about his new role as a trustee for FIGO in the Asia Oceania projects, and he's been the editorial board member of the Global Reproductive Health and IVF Worldwide. He has several awards and achievements, 59 awards, including the honorary FRCOG Fellowship. He's received several awards like Physician Award National, BN Purandare Award. He has been the editor of several books, delivered several lectures, and his past positions have been past Secretary General, Senior Vice President, and Deputy Secretary General for FOGSI. He's been the past president of ISAR, IAG, MOGS, Maharashtra chapter of ISAR. He's been the past professor at DY Patil and Lilavati Hospital. Welcome, sir. We request you to please speak a few words to encourage.
Thank you. Thank you, Parna. I'm really grateful to, first of all, Madhuri, who is a very good friend of mine, very competent Secretary General, and I'm sure that she will achieve her goals, whatever she has set in the future. And then, of course, I would like to recognize Dr. Tank, who is our president, who is very dynamic, and Dr. Adi Dastur, who is our past editor emeritus of the journal. And also, I would like to recognize Padnya and Supe, Dr. Padnya Supe and Padnya Changde and Dr. Sunil Kamekar who are doing this. And the three chairpersons, Dr. Sujata Dalvi, who is my classmate as well, very dynamic. And Dr. Alka Pandey, who has been my vice president, and Dr. Kiran Maini, who also is a very dynamic chairperson of FOGSI. And Vandana Bansal, of course, is going to talk to us about the invasive prenatal testing, and Poonam Yadav is going to talk to us about hypertensive disorders of pregnancy. So, first of all, I would like to say that, during our year, that last year, there was a very hectic year for me. And besides a lot of the clinical thing that I did, we also, along with Madhuri, we did a lot of academic activities, especially the GCPRs, nearly 26 of them. A lot of them are in process of getting printed. We had more than 20 plus books. Again, many of the books are getting printed now, and 20 plus focuses as well. So that has been, for me, a very important part of my, presidency. And this year, of course, I would like to say there are three important, especially the AICOG is very important. So we need to, of course, Mumbai, all of you will be there, the All India. And then next year is the annual FIGO conference will be in Paris in October from 5th to the 9th. So we must all, I think this time the biggest contingent should be from India when we go for the FIGO in Cape Town. So a lot of things are happening. For me, it's like a roller coaster ride. I'm just now at the I'm at the Mumbai airport going to Delhi for a meeting. And so then I will meet many of you in the Calcutta meeting. So it's a great, and journal has been a very important pillar of our, FOGSI. As Madhuri has said, there are three main mother body of the federation. That is the FOGSI, and a lot of you are in the FOGSI journal, and it's a very important, and especially our journal is very well respected all over the world. So, and proud to be part of that as well. So thank you very much for inviting me here, and wish you the very best. And thank you, Madhuri, again for calling here. And I hope I have not missed out on any important person. If I am not, I can see Geeta Balsarkar there. She's put her video off, but there are many others which I don't If I have not taken the name, please excuse me. So thank you and wish you the very best.
Thank you, Rishikesh, from your busy schedule. You have taken out the time and you made it a point to join over here. So this is inspiration for all of us. And thank you once again for joining for this webinar. Thank you.
Thank you, Madhuri. Thank you.
Thank you so much, sir, for always encouraging us. I now request Maria to display the slide of our guest of honor.
And one
Dr.
more thing, I forgot to take Maria's name. Maria is also a very important part of our channel. Thank you.
So let me invite Dr. Adi Dasu, sir. He is our guest of honor for today. He is the editor emeritus of JOGI. He is the former honorary professor of OBGY at Bhatia Hospital, BD Petit Parsi General Hospital, even Badia Hospital. He's been the panel of Breach Candy Research Center and Hospital. He's the founder, fellow, and former governing council member of IAG, past president IAG, dean of the Indian College of Medical Ultrasound, past president of Indian Society of Prenatal Diagnosis and Therapy. Of course, he has contributed a lot to JOGI. He is our editor emeritus, past senior vice president of FOGSI, past committee chair for medical nomenclature, norms research records committee of FOGSI. He has over 300 papers published. He is a Rotarian, past president of the Rotary Club of Mumbai, past president of the Mumbai OBGY Society. He's been the trustee, former chairman of the Health and Fitness Subcommittee. Has sir logged in?
Ma'am, I don't think so.
Some time. Yes, Maria?
I don't think so. I can't see him, though I have
Yeah,
saved.
yeah.
Yeah,
But
even
he
I
will
can't
log in
see
in
him. I
some
think we
time.
can go ahead, Pradnya.
Yes, yes. Okay. So now I request Dr. Sunil to introduce the chairpersons and begin the session.
Good afternoon, everyone. Respected seniors, faculty, and dear delegates. We welcome you at this scientific webinar session at JOGI. Standing on the shoulders of giant is the principle what we believe in and we follow at our work at JOGI, promoting research and academic activities. And in fact, nowadays, various organizations as well as universities have made it compulsory for the students to have publications with the standard index journals like JOGI. So now moving ahead with the further session, I invite chairperson for the session. First chairperson, it's my proud privilege to invite Dr. Sujata Darvi, madam. She's senior obstetrician and gynecologist. Currently, she is holding post as the treasurer of Mumbai Obstetrics and Gynecology Society at Journal of OBGYN of India, JOGI. She is associate editor. She has been president of Mumbai Menopause Society. She is past secretary of MOGS. Very active practitioner in city of Mumbai and honorary clinical associate Wadi Hospital. We welcome you, ma'am. Dr. Alka Pandey, she is senior obstetrician and gynecologist. She is professor at Narayan Medical College, Saharsa. She is our national corresponding editor at JOGI. Ex-associate professor at PMCH Patna. She is being vice president of FOGSI 2022-2023. She has been part of various organizing conferencing events overall. We welcome you, madam, and she also has been working at Asian Healthcare Commit Awards, and she has been received Best Gynecologic Award of at Bihar 2021. We welcome you, ma'am. Next chairperson is Dr. Kiranmai Devneni. She is senior obstetrician and gynecologist. She is professor at Kaloji University of Health Sciences, Telangana. She is our national corresponding editor at JOGI. She has been very active person at FOGSI and has been playing roles at various committees of FOGSI. Chairperson to FOGSI No to Wow Committee 2022 to 2025, and she is being vice president of OG SH Hyderabad 24 to 25. She has been recipient of many awards. Needless to mention, importantly, is FOGSI Dhira Award 2021, and she has been part of various scientific committees and training sessions as well. We welcome you, ma'am, and thank you. I request all the chairpersons to introduce the faculty and the authors who are going to present. Thank you.
So thank you so much, Sunil. At an outset, before we start, I would like to express my gratitude to our editor-in-chief, Dr. Madhuri Patel, for starting this clinical pearls. I would also like to acknowledge the words of wisdom given by our past FOGSI president and my classmate, Dr. Rishikesh Pai, and waiting to hear from our current president, Dr. Jaideep Tang, and of course, past editor-in-chief, Dr. Adi Dastur. Before we start with our program, I would like to introduce our first speaker, that is Dr. Vandana Bansal. Dr. Vandana Bansal is an additional professor of obstetrics and gynecology at Nauroji Vadia Maternity Hospital, and she heads the department of sonography at Nauroji Vadia Medical Hospital. And of course, she is also director of fetal medicine at Surya Hospital, Mumbai. She was the first postdoctoral fellow of National Board in India, qualified in high-risk medicine and perinatology. She is heading the MUHS approved faculty fellowship for fetal medicine and also for MD ICOG course coordinator and faculty for certificate course in fetal medicine. She is the president of Fetal Medicine Mumbai chapter. And mind you, I must tell you, she's so well versed in fetal medicine that her words or her diagnosis is a gospel truth, and it's the last thing that you would want to, and whatever she says always comes out the truth. So her words is the final. And today we would like to have a privilege of listening to her. Her paper is on prenatal invasive testing at a tertiary referral center in India, a report of 433 cases done by a single person. So much is a workload and so much of experience that she has it, that we would like to listen into Dr. Vandana Bansal, what made her go into this fetal medicine branch and being an expert in the same. So over to Dr. Vandana Bansal, please.
Madam, unmute yourself. Dr. Vandana, please unmute yourself and share your screen.
Thank you so much, Sujata Dalvi, madam, for those kind words. And Dr. Madhuri Patel, thank you for inviting me here and starting this program. It's a good platform for everybody to speak out what they have done in their subject. So I think I will open up my presentation, and I will actually, why we started this prenatal invasive procedure publication is, when I was wanting to tell the patient about the counseling, we would always take percentages of British, UK based articles and other things. We wanted to have our own data to find out what are the problems that we have in the screening process itself, as well as in the invasive procedure, and what are the risks. So there wasn't any big data of Indian data to look at. So we thought we will talk about this. So this is a prenatal invasive testing at a one center, one operator of 433 cases that we published. So I will get into it. So Down syndrome, we know, is the most common intellectual disability. Birth prevalence of trisomy 21 in India varies from 1 in almost 1,000 to 30. So this is Indian data that we are looking at. Individuals with trisomy 21 may have some physical disability. So they could present on ultrasound with abnormalities, but there's a big number of these trisomy 21s which have no ultrasound abnormality, and they will be just picked up at birth if we don't do screening tests. So almost 50% of trisomy 21 doesn't have anything on malformation scan, and that is why we do the screening test. So Down syndrome screening is to be offered to all. That is a standard of care of most guidelines. We follow the same thing. So if we only look at maternal age, which we used to do some years back, that those who were more than 35, we would do amniocentesis, and the rest we won't do anything, would only pick up about 50% of Down syndrome. So we have started doing this first trimester screening for all. And this is the standard of care all over the world, that we do maternal age combined with an anti-nasal bone, combined with a dual marker, and we have a detection of 90%. with a false positive of 5%. This is the data which we have from various guidelines, but what is our data is what we want to understand. They also say that if you add markers like absent nasal bone, ductus, TR, along with this, we increase our detection rate to 95% for a false positive of 2.5%. So this is standard of care. Quadruple marker, if we missed out on the first trimester screening, we would do a quadruple marker between 15 to 20 weeks. Here again, the detection rate is almost about 80-82%, but we add a genetic sonogram to that, we would increase our detection rate. Again, this is all from world literature. So if the risk of trisomy 21 is higher than the specified risk cutoff, we would then perform an invasive procedure, or nowadays we would do an NIPT as well. So 5% of all pregnant women would actually end up doing an invasive procedure, again from UK literature. So with this background, why don't we, having so much of work that we are doing, why can't we have our own literature for this? So the purpose of our study was to examine the pattern and outcome of our screening procedure and our invasive results from one center that we performed this in Surya Hospital. So it was a retrospective observational study of 3 years between 16 to 19 June. The sample unit was all pregnant women with high risk for any genetic disorder which underwent an invasive procedure, which could either be a CVS or an amnio or a cord blood sampling. So in this 3 years, we had performed around 433 amniocentesis or CVS or cord blood. The inclusion criteria was anyone who had invasive procedure done, whether it was for a positive biochemical screening or a positive ultrasound marker, which was, there was an indication for invasive testing, or some other method of screening which came out as positive, or a previous history of a previous child with an index case with a genetic disorder. So we excluded all those where we had done a reduction or a therapy or a transfusion or any other invasive which were not diagnostic. So formal permission was taken from the Institutional Ethics Committee. The standard protocol in our center is that all patients who are referred for any diagnostic intervention, we do a re-evaluation. So we do an ultrasound again for all our cases. So it was done by a single FMF certified, myself, only fetal medicine consultant had done a re-evaluation of the baby, looked at all soft markers and any other anomalies or any kind of a growth restriction. So consultation with the patient would inform her about the procedure, its risk and complications, also give her any alternative options if available, the advantages, disadvantages of all of them. So this was a standard of care that we do for all the patients who have been referred to us. So valid informed consent was taken. If it was an amniocentesis, we have done with a 22 gauge needle. And if it was a cord blood sampling, it was done with a 20 gauge needle, and a CVS again by a 20 gauge needle, a single operator. Post procedure, every patient was given an oral antibiotic and a progesterone, although the guideline says that you may not need to give antibiotic and progesterone. But in India, it is what you would say, it is better that we give antibiotics so that we don't have an infection. So all of these were done in 3.5 megahertz curvilinear transducer, Voluson E8 and E10. It is a retrospective data. So we have a software from where we have collected all the maternal age, the indications, the family history, the ultrasound findings, and any other immediate or late complications were all asked from the patient telephonically. So during these 3 years, we had a total of 436 procedures, of which 433 patients. So there were 418 singleton, 12 single fetus of a twin, where we didn't have to do amnio for both the fetuses, we did for only one, and 3 where we had to do for both the twins because there could be some screen positive for both the twins. So our amniocentesis was the highest, 64.4%, 281 cases. Chorionic villus sampling was also a significant number, 35%, 153 cases, and 2 cases of podocentesis that we did. So most invasive procedures that we have done is for a screening positive for chromosomal abnormality, whatever it be, whether it was because of a biochemical screen or an ultrasound screen. Procedures were 85.5% were done only for some reason for a chromosomal abnormality that we looked at. But there was again a 14%, almost 63 patients where there was a previous baby with the abnormality or a family history of a genetic disorder or a family history of a genetic syndrome. But by and large, all 85% of our procedures were done for a screening positive patient. So if we look at these screen positive patients, if you look at the data of this 373 which had a positive aneuploidy screening and we did, the biochemical screen test was done in 49% of cases. That means it was only a dual or a quadruple which was positive and normal looking fetus. Ultrasound which showed some abnormality and was an indication for the amniocentesis was in 126 cases. Abnormal combined screen, that means there was a problem in the quadruple or a dual, plus there was an ultrasound marker also was seen in about 46%, 40 cases, and previous baby with Downs was in 17 cases. If you look at these data, you will see that the positivity was highest in the one where there was a combination of a scan and a biochemical problem. So 13% in those where there was a combined problem. And ultrasound alone was also about 10%. That means the ones which have got an ultrasound abnormality had a very high chance of having an abnormality. However, if it was only a dual marker positive or a quadruple marker positive and nothing seen on ultrasound, only 2% of them really had a Downs or any other aneuploidy. Also, in babies where there was a previous baby with Downs, there were 17 such cases. There was only one patient who came as positive, and this was a 21-21 translocation Downs. All other non-disjunction Downs were normal. So this data is very important for us to understand that if you have a dual quadruple positive, then reassure the patient the chance of this becoming positive is only about 2.7%. However, if I find something on ultrasound, that is the one where we should be little careful in telling the patient that it could be all right. So here you see if it was 11% true positive, if there was an ultrasound marker with or without a biochemistry. So the total, that means if we have an ultrasound abnormality, we tell the patient there may be 11% chance there could be a problem, while still 90% around will not have a problem. However, if it is only screen positive, the positivity rate is only about 2.7. So true positive for only screen positive is only 2.7%. And if we combine everything together, the screen positive for all our cases, 370 was 25. So among 370 that we did an amniocentesis for, there were only 25 which really came out as positive. So again, what we understand from this is that anybody with a screen positive, don't tell them to terminate the pregnancy. They need to have a test done. And if the test is done, 6.7% might have an abnormality, is what our study says. So now if we look at what type of tests were done, so there was dual marker done in 50% of cases, quadruple done in about 40% of cases, and still in 2020 world, we still have some triple markers being done. So one is, although triple marker is completely obsolete, they are obstetrician who are still continuing to do triple marker tests. And maybe that is what we need to tell them, that triple marker doesn't have a good detection rate. So among all our cases, the true positive in the dual marker was 4%, while in the second trimester, it was only 1% true positive. That means dual marker positive has got more importance than a quadruple marker being positive. So the true positive is very high for a first trimester screening. Now let us look at the screen biochemical risk cutoffs. Cutoff means what is the risk written on the dual or the quadruple marker. So literature says that the higher the biochemical risk, higher the chance of having an abnormality. But what we found is that when it was 100 to 250, that means this is high risk. Probably you can say intermediate risk, the chance was 4% of it being screen positive. 150 to 100, it was 6%. Less than 150 was only 3%. And more than 250 was 0 for intermediate risk. So there was actually no big significant difference between the risk. So it doesn't mean that if the risk is less than 1 in 50, the chance is higher for a Downs baby. And if it is risk is between 100 to 250, the risk is less. So our data did not correlate the biochemical risk cutoffs with the risk of having an abnormality. So the risk doesn't matter. It is either screen positive or it is screen negative. It is screen negative, we will say that the detection rate is this and you are screen negative. If it is screen positive, whatever be that risk, if it needs an invasive test, we cannot say that if the risk is high, the chance is high. So we saying that 1 in 50 means among 51 has a problem is not the right way of explaining to it. And if it is 1 in 100, among 100, one has a problem. So what we have to follow is that among all these biochemical screen positive, the chance of having a screen positive, having a true positive is only 2%. And that is what we need to tell the patients. So now we go on to markers. So among all the markers, we actually looked at increased NT, absent nasal bone in the first trimester, absent or hypoplastic nasal bone in the second trimester, any major abnormalities which were appearing to have a aneuploidy, and growth restriction. So the highest association with aneuploidy was in the increased NT group among 34, 42 patients, 8 had a problem in the amniocentesis report. And second is if there was an absent nasal bone. So 4 out of around 30 had a aneuploidy. So among all the markers that we have, increased NT and absent nasal bone are strong markers and we need to look at it. Now what we did next is, among the NT also, the literature says that if it is 95 to 99 centile, then the risk is high. And if it is more than 99 centile, the risk has to be much more than that. But what we found is 95 to 99 centile, 25% had a positive report, while more than 99 centile, it had less than what we had in the 95 to 99 centile. So higher the NT does not translate into having an aneuploidy. However, in this study, we did not have a microarray at that time because microarray was not so easily available. Maybe all these which were more than increased NT could also have some microarray abnormality, which was not picked up on the karyotype. And so this is one of the limitation of this study because we did not actually look at microarray abnormalities in this. But higher NT did not translate into having aneuploidy in the patient. So now among all those which had an NT above the 95 centile, 12 of the 42 cases of increased NT had some associated abnormality. 3 out of these had an aneuploidy. So 25% actually had an aneuploidy. If it was associated with an abnormality, the risk was high. And if it was isolated also, 5 of them really had an abnormality seen. So the total among all of them, there were patients who terminated pregnancy only on the basis of an increase in NT. And so the take-home baby rate was around 61%. So learning from here is increase NT is not for termination. Increase NT is to test the baby, especially if increase NT is associated with an abnormality. The chance of having an aneuploidy is significantly high. But if everything else is normal, the take-home baby was almost 61%, which had a completely normal structural genetic baby at birth. So now coming to absent or a hypoplastic nasal bone. 22% of all absent nasal bone that we had trisomy 21. So although literature says that Asians have got more chances of absent nasal bone and they are not associated with aneuploidy. So the likelihood ratio for absent nasal bone is less for Asian population. We did find 22% of all our cases had trisomy 21. So that is a significant percentage, much more than even an increase NT. So I think even for India, absent nasal bone should still be considered as a very strong marker for which we should do amniocentesis or maybe an NIPT at wherever the choice is to do an NIPT. Another thing we learned is that all those who had a hypoplastic nasal bone, none of them had a Down's baby. So I think for Asian population, the size of the nasal bone has to be taken as per the Asian population and not as per the British population or the world literature. So our nasal bones that we measured, we followed the FMF guideline, and by that hypoplastic nasal bone was in 9 patients. None of them had an aneuploidy. So I think hypoplastic nasal bone has to be followed by Indian database. Now coming to major abnormalities. So we had 51 cases of major abnormality which appeared to be connected with aneuploidies. But among all of them, around 10% only had an abnormality. So among these 51, 5 had, so it comes to about 10%. So even if you have abnormalities like a duodenal atresia or a tracheoesophageal fistula or a diaphragmatic hernia, where we think the chance of chromosomal abnormality is very high, it still is about 10% only. 90% may not have an aneuploidy in these babies. And if it is a correctable disorder, it is better that we counsel the patient, tell them about the results of correctable disorders, do an amniocentesis, find out it doesn't have a chromosomal abnormality, and then continue and deliver in a tertiary care center where you have facilities available. What was surprising to us is the growth restriction. So we had 23 cases of growth restriction, which we had to do an amniocentesis for. So these were all early onset growth restriction, where uterine arteries were normal. So we actually thought that they would be a fetal cause for that. So amniocentesis was done in these 23 cases of the total for IUGR. Of all of them, 82% had other associated abnormalities. So of all these early onset IUGR, looking at the baby to see for other abnormalities is very important. Echogenic bowel, any other structural abnormalities. Of all of them, 2 of the 23 had trisomy 18. So trisomy 18 is associated with IUGR. So of these 23, 2 had trisomy 18, 1 had a CMV positive, 4 had no anomalies, normal karyotype. Of these 4, 3 had an intrauterine demise. Only 1 of them survived. So among 23 invasives that we did for IUGR, there was either some genetic disorder or an infective disorder, or they ended up in a fetal demise, and only 1 of them survived. So IUGR is something that we need to also counsel patients for genetic testing, especially if associated with an abnormality. So coming away from the aneuploidy to other rare genetic disorders. So 63 patients of our total 433 cases were done for something other than aneuploidy. So here we did a karyotype for all of them, but in addition, we either send for a Sanger mutation of the index child or a clinical exome. So there were 14% patients who actually did have to go through an amniocentesis or a CVS, and this is a big chunk. So earlier chromosomal abnormalities were the major chunk, but now people have become aware, and so people are sending patients who have a previous baby with a dysmorphism or having a mental retardation or confirmed diagnosis of Fragile X or an osteogenesis imperfecta or all these disorders which come to us. We first evaluate the family, the index case, and then we do an amniocentesis for them. And of these, 23% had a true positive. That means for an aneuploidy, I said we take 6.2% true positive. For these genetic syndrome, which is very much more important, 23% were positive for an abnormality that we saw. So any baby with mental retardation or a dysmorphic baby, it is not do amnio for karyotype. You need to evaluate the whole family, find out the index case, and then do an amniocentesis and find out the disorder which is there in that family itself. So now coming to what our procedures were and what were the complications for all these 433 cases. So we had a single prick for our procedures, whether it was amnio, cord or CVS. 99% single prick, only 3 patients required a double prick in our cases. Among all these, amniocentesis were 281, CVS 153, no invasive related complication, except in CVS, there were 3 patients who had some spotting because they had placenta previa and culture failure rate in 2 of the cases. No losses, no leak, no chorioamnionitis, no repeat procedures were done in all these cases. The 1-2 which had a culture failure, we had a fish done and the fish was normal. So now if I go to discussion, there is only one big study which is actually not as big as what we have. So what they did is they looked at prenatal aneuploidy screening, its evolution and trends. So they looked at 3 years data, and they also found that the screening uptake has increased from 40% to 86%. Again, for them also, the most common indication was a chromosomal aneuploidy positive, and the same for us also. So the diagnostic yield that they said was 4.7%. Our diagnostic yield was 6.7%, slightly higher because it's a referral center for all screen positive cases. And 93% of our patients were reassured of the normalcy, and we allowed these patients to continue pregnancy. Previous literature used to say 5% of the positive high-risk cases have a trisomy 21. Our percentages for Indian population, 6.7%. So in that study, they had less number of CVSs and more number of amniocentesis. The percentages was very less. They only had 10% of all invasive CVSs. We had a huge number of our CVSs because 35%, because I think we have maybe Bombay has started screening and doing dual marker more often. And so if dual marker comes as positive, they come to us early and we are able to find out the disorder early. So our number of CVSs is significant number, about 35%. And the results and the risk and complications are same. So the indication for invasive procedures they have looked at is only ultrasound, only screening, or previous baby with a Down syndrome. And almost similar study that we had abnormal screening 49%, abnormal ultrasound also 46%, and previous Downs were 5% of all the cases that we had. And again here, the chance of having screen positive was very less for only biochemistry, high for an ultrasound with or without biochemistry, and less for a previous child with Down syndrome. So ultrasound additional markers, are they useful? So it is extremely important to look at the fetus before we do an invasive test, because these additional ultrasound markers increased our positive predictive value from 2.7% for biochemistry to 10.3% for a strong soft marker present along with the biochemistry. And so it is important that we don't just look at the biochemical risk and follow it. We need to look at the baby again if it has not been seen. And if there are markers, then the risk of aneuploidy is high. So the value of biochemical risk cutoff should not decide the chance of a true positive as per our data, that if the risk is very high, the chance is more, and if the risk is less, the chance is less. Even in other studies also, they have quoted the same thing. So NT implications. So increased NT in our case were associated with 19% of cases with Down syndrome, and higher the NT was not actually associated with higher chance of an aneuploidy. But I think we need to do a microarray for all those cases, and this was not assessed in our case because at that moment of time, microarray was not a standard of care, and we have not looked at it. So increase NT, anything more than 95 needs to be tested by a CVS or an amnio, and it needs to be tested for a microarray and not for only a karyotype. So last of all, nasal bone implication. In our series of 28 with absent nasal bone, when 14% had Down syndrome, and none of the baby with hypoplastic nasal bone had a problem. So I think the hypoplastic nasal bone definitions have to change according to the Indian population, and we should have our own data for the sizes of the nasal bone. We have one from Bangalore, but here we followed the FMF data for a hypoplastic nasal bone. But I think we need to change our sizes of nasal bone. But only absent nasal bone with or without abnormalities has still a high chance of having Down syndrome. So you cannot leave absent nasal bone even if there is no abnormality and say that it may ossify later on, and maybe we look at the screen positive and decide that. So it appears likely the race and ethnicity have some impact on the length of the nasal bone, and Asian cutoffs should be used. Major abnormalities. So these surgical correctable abnormalities should not be terminated only on the grounds that they have a strong association with aneuploidy, but all of them need to undergo an invasive test, both if they are terminating to determine the recurrence risk, but if they are continuing to prognosticate and also tell them that these are correctable disorders, and if there is no aneuploidy, we can continue these pregnancies and give them a good baby rate. Growth restriction is the worrying part. If there is any abnormality but association with fetal growth restriction, the counseling has to be very, very careful, because in our study of 23 FGRs, only one of them survived and went home. All of others either had a chromosomal abnormality or an infection, or finally there was a placental disease which the baby succumb to. So additional association with syndromes and single gene disorder should also be important. And these say all these FGRs, if when you are doing an amniocentesis or a CVS, keep the sample saved for DNA, because they could have other abnormalities which are microarray related or a single gene disorder. So in addition to only looking at karyotype and infection, do a microarray and keep the sample saved if the patient is not affording. Role of fish. It is important that fish is done only for 13, 18, 21. And all these patients who are screen positive might sometime have some other aneuploidies. So doing only fish is not an answer. We actually did fish for all our cases, but they were all followed by a karyotype abnormality. The guidelines say that the procedure-related risk is 0.1 to 1%, and for choriomyelitis 1 to 2%, and for a culture failure, our results were much lesser than that, and maybe our overall complications documented in our study was low because it was a single operator who had an experience of more than 20 years, and there were strict protocols followed for pre and post procedure care, and our complication rates were almost nil. Yes, we did have 2 culture failures in our cases. So both of them were done for a screen positive, and both of them were a CVS sample. So CVS sample, the culture failure rate is actually more, although literature says the failure rate is almost the same for both of them. For both of them, fish was done. So it is always best that baseline FISH is done for all our cases before the culture also comes out. So if the culture failure happens, then we can actually counsel the patient that if the screen is only for trisomy 21, then the FISH is almost 100% for trisomy 21. However, it may not tell for other things. So these two patients were counseled. If they really want, we would redo an amniocentesis, or we would go by the FISH report. So both of them, because the scan was normal and the screen was only positive and we had a FISH report normal, we allowed these patients to continue pregnancy and both had a good outcome. So the limitation from our study is that we have not done a microarray for NT increase as well as for patients of malformations as well as for IUGR babies. And so probably we need to have some more data, maybe a new study at looking at microarray abnormalities in these cases, which we are ongoing, we are doing for malformations, exome and microarray abnormalities. We will come up with those data after some analysis. So what points we all know from global literature and we have substantiated from our study was: one, aneuploidy screening is the most common indication for prenatal invasive testing by either dual marker combined with anti-nasal bone ductus and TR, and they have the best detection rate. We also had a good detection rate with the first trimester screening test. Highest association with aneuploidy was seen with increased NT and an absent nasal bone. And among all abnormalities, cardiac had a problem. 19% of our fetuses with increased NT had a chromosomal abnormality, and 5 out of 42 had a major structural abnormality along with this. So this may increase once microarray is tested for all these increased NT. So among increased NT, 19% had an abnormality. Among fetuses with major abnormalities, 9.8% had an abnormal chromosomal report. So anomalies which have markers, strong structural abnormalities, amniocentesis should be done. Early IUGR are usually associated with poor outcome, 95% in our study. However, the yield of invasive testing for aneuploidy and infection was low. Only 3 out of 23 had some abnormality. A diligent look for structural anomalies, markers of fetal infection, and Doppler must be done. It is worthwhile to keep DNA saved in all these severe IUGR for genetic evaluation in the event of a fetal demise later. There are significant number of babies with dysmorphism, neurodevelopmental delays, cerebral palsy, mental retardation, where the chances of recurrence, as in our study, was 23.8%, and all of them will need evaluation along with the index case workup. FISH alone may not be conclusive and should always be followed by a full karyotype. Among CVS and amniocentesis, they are not associated with significant increased risk of miscarriage over the background risk. There is no evidence that CVS is less safe than amniocentesis. Complication rates can be minimized by expert operator and strict protocols for pre and post-procedure care. What additional information we got from our study is the chance of an affected fetus in a patient with aneuploidy screen positive overall is 6.7%. So when a patient comes with a screen positive, you tell them the chance of this being abnormal is 6.7%. This is Indian data. The higher the biochemical risk does not translate into higher chances of abnormality. So 1 in 50 or less than 1 in 50 doesn't translate into really having a Down baby. So you need to counsel them and reassure them that let us do a test and then we decide what the report comes out as. The probability of an invasive test report coming abnormal increases if there are additional ultrasound markers. So if in addition to biochemical test, we have an ultrasound marker, then the chance of abnormal report coming is 13%. Again, an Indian data. So this can be quoted for our patients. The positive predictive value of a biochemical marker alone was only 2.7%, higher with combined first trimester, first or a second trimester with abnormality. So only biochemical screen positive, only 2.7% will have a Downs baby, while if it was associated with abnormality, it was 13%. 21% of fetuses with absent nasal bone in our study had trisomy 21. So we need to use lower centiles for Indian population for hypoplastic nasal bone, as none of our patients with hypoplastic nasal bone had trisomy 21. But absent nasal bone is a strong soft marker and should be tested for trisomy. For rare genetic disorders, evaluation in the neonatal period, collecting the neonatal blood for DNA preservation in genetic lab is invaluable. And this DNA saving is only about 1,000 rupees. And if the baby dies, at least we have the sample so that we can evaluate these later on for the next pregnancy. And there the chance of it being positive is almost 25%. So very important that dysmorphic baby which is born should be tested in the NICU itself or wherever the baby is for at least keep a DNA saved for these cases. So we routinely use figures and percentages from global publication. This is a large patient data of invasive procedures from India, which can be used by clinicians to develop in developing countries to counsel women on the odds of invasive report coming true positive, and the risk of procedure related loss is very less if it has been done by experts. So, madam, I would finish on this.
Yeah.
I'm
So
open to comments,
no
ma'am.
problem. Thank you so much, Vandana, for great explanation and everything about, this aneuploidy screening. What I wanted to reiterate is hypoplastic nasal bone, not of that much significance so far as Southeast Asian countries are concerned, and we need to have a proper standard. If it is an FGR with fetal anomalies, one has to be very active about the whole thing because there are chances that you could have an IUFD or some sort of a problem along with the baby. And the third thing was of importance is complication rates. Of course, if it is done by a single person, it's much less, so one need not be very much worried. But one thing I wanted to ask you, Vandana, is we get this aneuploidy screening done up to 13, maximum up to 14 weeks, and amnio goes around 16 to 18 weeks. There are some patients who are always willing to get an NIPT done, So what do you, of course, this was not in your study, but how do you go about getting, because we do get an NIPT done because by then patients are a little bit okay getting it done. And by the time you tell them about amnio or something, it still takes little time. So how do you go about it?
So, madam, the ones which are biochemical screen positive and I don't find anything on ultrasound, then you could option of an NIPT is okay for them. But if I find an increased NT or an absent nasal bone or any other abnormalities or cardiac abnormalities, we would then tell them NIPT may not be a good option. But where it is nothing else and it is only a screen positive, as what I said, only 2% had Down syndrome, and that also can be picked up on an NIPT. So if there is no ultrasound markers on a first trimester screen also, or for that matter, quadruple with a normal anomaly, we could offer them an NIPT.
Yeah, so that could be offered, no? Because that way they are a little bit receptive about undergoing the things, Otherwise, it's very difficult for them to tell, oh, you wait for another 4 weeks and get an amnio done and this and that. This gives them a little bit of a, I would put it as laying it down, and then they are willing to get it done. That is what it is. Well,
and if there is an abnormality, we do a CVS.
Then there is no question.
Amnio, ma'am. Then we don't wait for an amnio also. We do a CVS before 14 weeks.
Correct. But sometimes they're not willing for CVS, so you need to give them some other option. So, this was another option that we generally like to give it in the practice before you tell them that you need to undergo amniocentesis. I would request my co-chairperson Alka and Kiran, my Devineni, in case they need to ask us something or they need to put in some points.
Yeah, I also wanted to ask, when the double marker or the this quadruple marker comes positive for suppose trisomy 21, so and the ultrasound TIFA does not show any abnormality, should we go for NIPT? You've just asked that question.
Yeah.
Should we go for NIPT? If it is normal on screen, on anomaly is not there and NT is also normal, then we can offer them an NIPT. But with the counseling that NIPT is 99.8% and not 100%, And in case it comes as positive or it says
they have to do
no
it.
call, then we will have to do an amniocentesis. With that, I think the screening number of invasives have come down because
Correct.
we have been able to do a lot of NIPT in these cases.
That's right, because
So-
that's also a screening test, but because it
Yes.
is non-invasive, na, patients are
They
willing
will
to
ask.
undergo that, that is what
So
I just wanted
ma'am,
to
the
tell.
only problem in that is that NIPT is done and then they come to us with some structural abnormality. Then
Abnormalities,
the
yes.
counseling becomes very difficult. So
I
first a
understand.
good scan has to be done and then offer an NIPT.
Yes, okay.
Thank you,
Thank you, ma'am.
Vandanji.
Yeah, that was wonderful, really wonderful. I know you are an expert, and it was a real great pleasure listening to you. I think Madam, Dr. Sujata Madam and Dr. Alka Madam had put in the very important query and also summarized. So I was just about to ask the anxiety levels of the patients and the counseling. So post your study in your center or personally, has it really made a difference in counseling? Even for us as general OB-GYNs, this kind of figures and all have clarified a lot of things for us, made things easier for us to, even talk to the patients about the tests and the importance of the ultrasound and all.
Yes, madam. One is our counseling percentages have started according to our own study. So we've started telling them the risk is not very high. Rest assured, if there's no anomaly, there's only 2% chance that there'll be a problem. And also the complications. What earlier literature used to say was 1% risk. Now we give a risk of 1 in 1,000, so 0.1% risk. So if we tell them the risk is so less, then they are more counsel better for invasive testing. And yes, NIPT has come up on a good method. And so all these also, we give an option of an NIPT to all of them, except where there is an abnormality. There, I think we should not give them an option only of an NIPT, where there's a structural abnormality. But we use our own percentages, madam. We've stopped using world.
I think these percentages and the figures that I have quoted that from our own Indian data, that really helps us, everybody to, counsel and give the real picture.
Yes.
Thank you so much.
Thank you, ma'am.
Vandana, I would like to say something. First, I will comment that I must congratulate you that this is the first Indian, data we have got it, and we can always quote it. And what important thing you talked about is the hypoplastic nasal bone, which you said it is not that significant in our Indian or Asian population. So that should be conveyed to all our obstetricians. As now the general obstetricians are also becoming more and more aware about this aneuploidy. So they are also going for that, but they don't have a clear idea when to go for what. Because many of them just go for NIPT over normal, don't go for anything else. So that should not be conveyed to them. Even your NIPT is normal, still what you suggested that your anomalies and NTs are very, very important marker in this. Now I have a question. Then you must have had a twins. Twins, of course, do we have a different biochemical markers? Do you have a different, reading something? Can you tell the, our delegates?
So, madam, for singleton, our detection for dual marker is 95% if we have seen everything. For twins, the detection rate is slightly low, but it is still about 91%. So, if a good NT and a good nasal bone ductus TR has been done with a good biochemical screen in the first trimester, then the detection is good, 92%. NIPT also has a good detection. The problem with NIPT is it will give the report of both the babies together. So if it is a DCDA twin and one is Downs and one is not Downs, the screen will come as positive for or intermediate risk NIPT. So we will have to test both the babies then.
Yes.
So for all these dual markers, problem is that if it comes as screen positive for one, we will actually have to test both of them. And quadruple again. So dual marker, at least you look at the NT and CRL. So you'll get two different detection rates. For a quadruple risk positive, it will come as a combined report. So both of them will only have the biochemical risk assessment. So quadruple detection in twins is less. maybe 80-82%, but first trimester screening is around 92%. So it is good to do first trimester screening in all twins. Should not miss that, because that is the most important screen for a twin pregnancy. Quadruple is not very good. It can be done, but the detection is not very good, ma'am.
So basically, when there is a dizygotic twin, and and any twins where you find abnormality in the first trimester as on nuclear translucency, NT, as well as the biochemical marker, you have to do for the both the twins, both the babies.
For both the babies.
But the babies. And the very interesting, you said that you can do the chorionic villus sampling up to 14 weeks of pregnancy. Because when I was going through your study, you have done all the trans-abdominal procedure, whether it is an amniocentesis or whether it is a choriovenous sampling. So what is the ideal time to do choreo CVS?
Madam, after 11 weeks, so it is 11 to 14 weeks we can do. Earlier we used to do transvaginal or transabdominal. So transvaginal has a more bleeding and risk of miscarriages. So that has almost stopped. So only if it is a central low-lying placenta, then we will do transcervical. Otherwise, all of them are done transabdominal.
So basically, after NT and after the dual marker reports, you will do the CVS if there are 11 to 14 weeks, right? And after that, you go for the amniocentesis. Now, I'm really happy that, what you say, the counseling of the patient is very, very important. If this marker comes, abnormal, dual marker and NT. So, as you said, only 6.7% in our study, showed that they have really had some unemployed. So the message to everybody is that the counseling of the patient and the relative is very, very important, and that is playing a very important role. I remember one of my, patient, she was elderly patient, and those days we used to do a dual marker and quadruple marker. So I'll tell you my story of the patient later on, but I want to know, once you do a dual marker, are you going to do quadruple marker also?
No, madam.
No.
So if dual is done once, that is a better test than a quadruple test. So the detection for dual marker is 93, 94, quadruple is 84, 85. So you don't do a worse test after doing a good test. So if dual marker is screen low risk, we don't repeat the quadruple. And if the dual marker is positive, also we don't do a quadruple, because anyway you will not depend on that quadruple.
Serious, yes,
What
serious.
you can do is, there is a some labs do a integrated test. So dual marker is combined with a quadruple marker, and a final risk is then. That is called as an integrated test. That can be done.
Okay, but when it is advised?
So dual, they don't give a report after the dual. Then we do a 16 weeks quadruple.
And dual report
then
is
a
not.
report.
What do you mean by integrated, test? When we suggest?
Integrated, if it is intermediate risk on a dual marker.
Okay.
But now that NIPT has come in, that is not used at all, because if you have an intermediate risk, we will do an NIPT. So that integrated is no longer used much in clinical practice.
So now, I can narrate one of the story. This was done many years back when we used to do a dual marker as well as a quadruple marker. So this one of my patient was the secondary infertility. She conceived with the ovulation induction, and she was 35 plus years old. And I did a dual marker and NT that came out to be negative. Then I went for malformation and the quadruple marker, and the quadruple marker was showing high risk. So, and then we only did a amniocentesis, and that turned out to be abnormal. And so we, the quadruple marker abnormal, and we did the amniocentesis, and that amniocentesis fish was normal, but the microarray showed the translocation, some part of thing. And then we say, okay, let us, our parents also get it done, karyotyping. And the father was having the same problem, genetic problem, and we allowed her to continue the pregnancy because father was healthy. So we said that this is the same thing, so we should allow her to continue the pregnancy. And today the child is almost, I think, 7 to 8 years and doing absolutely well. So sometimes these tests are very scary. At the same time, we have to do a counseling to our patient very well. And I'm very happy that you have presented this, but I want to know one more thing, that when you say fetal growth restriction, retardation, how early you can go for amniosis? How early, there should be fetal growth restriction, and how early you can go for the amniocentesis?
Ma'am, 16 weeks is for amniocentesis. Very early fetal growth restriction can even happen in the 12 to 14 weeks also, ma'am. The ones which are triploides and trisomy 18s, they will have a smaller CRL even in your NT scan time. So if you have a early dating scan and it is normal and your CRL is actually very less, we will call it as early onset IUGR even in the first trimester. But mostly these all were the ones who at anomaly scan showed a centile of first centile, and then the Dopplers were done. Then we looked at echogenic bowel and amnio was done. So mostly we pick up at our anomaly scan these early onset FGRs, and rarely this NT time also. And especially these have a very high chance of triploides and trisomy 18s.
Sometimes with the malformation scan and all, they give, soft marker, positive spot, some bowel, echogenic bowel, cardiogenic. So if we have more than one, then we consider. But do you think if with one also we should go ahead with the other invasive test?
So, ma'am, there are 4 soft markers that we should test even if the screen is positive. If there's a nuchal fold which is increased, is a strong marker, likelihood ratio of almost 5. Absent nasal bone is the second marker. You might have a first trimester nasal bone seen and then show as absent, because there even a dot is considered as present. Here it absent nasal bone. Then if there is ventriculomegaly, and fourth is if there's an absent aberrant right subclavian artery. So increased nuchal fold, absent nasal bone, ventriculomegaly, and ARSA. These are 4 strong soft markers where even one marker you need to test them. But other things, choroid plexus,
Echogenic bowel.
pelvic tests, these are not markers strong enough. For all of them, you could just leave it, or may want to do an NIPT, you could do that. So they all have a likelihood ratio less than 1. So if your risk was 1 in 1,000 and you have a choroid plexus, then it still remains 1 in 1,000. But if it is 1 in 1,000 and nuchal fold has a risk of 5 likelihood, so you will multiply this 5 with this 1,000. So your risk becomes 1 in 200. So your risk increases. So you multiply your first trimester a priori risk with the marker likelihood ratio. So all have absent nasal bone is 4 likelihood ratio. Ventriculomegaly though is associated with lot of other abnormalities. So these 4 you will do an amnio, ma'am, even if the screen is negative.
Thank you for enlightening us. And back to our chairperson for the further comments.
Madam, Dr. Pradnya Supe has put his hand.
Yeah,
Dr.
Sujata, yeah. So,
Yeah,
it was
we
an excellent
request our next
presentation.
co-chairperson to introduce our next speaker then. Dr. Alka or Dr. Kiranmai?
Yeah, sure.
Yeah, please
Come on.
show the slide of Dr. Poonam. Maria.
So, Dr. Poonam Yadav is going to talk on a prospective study to determine the predictive ability of HDP gestosis score for the development of preeclampsia. And can you show her CV? So she has many special awards and achievements. The FOGSI Korean Award Junior category at AICOG 2016. FOGSI Movicol Korean Award Senior category at AICOG 2023. Then FOGSI Dr. DC Datta Prize by FOGSI for Best Handbook published in 2020. Then Dr. Jagdishwari Mishra Prize for Best Poster Presentation in AICOG 2020. Then Shri Prabhu Dayal Baveja Medal for the best paper published in the Journal of UP Chapter of Obstetrics and Gynecology. Best Paper Presentation Award in UISAR 2019. Then Best Paper Presentation in 9th Conference of South Asian Federation of Obstetrics and Gynecology and UISAR 1019 at Agra, coordinator of various national live workshops on laparoscopy and vaginal hysterectomy, guest speaker, moderator, and panelists at various international and national conferences, and Achievers Award by AOGS in 2012, 14, 16, and 17, and joint editor for AICOG 2016, editor AOGS 2019 and 20, present secretary Agra Obstetrics and Gynae Society. And she has more than 40 publications in various international and national journals and books, published a handbook on common medical disorders in pregnancy as editor AOGS. So, Dr. Poonam, we are eager to hear your talk.
Thank you, ma'am, for kind words of introduction. I just share on my screen. My screen is visible?
No, ma'am. Open your PPT now.
Can you share at your end?
Pradnya
I
madam,
think
can
you
you
need
share it?
Yeah, you need to close it down, minimize, open it, minimize,
Yes.
and then try
I
once,
think you
Dr.
stop
Poonam.
screen sharing. Will you stop screen sharing? First, you open the
Just
PPT
a second. Okay.
and minimize it on your taskbar. Open the PPT and minimize it on your taskbar. Then you press share screen and then select. In the meantime, Sunil, please open it from your end. Yeah. Could you open the PPT and just minimize it? Don't keep other PPTs open. Just keep that one.
Now it is shared.
Now you type share screen and select. Yeah, we can see your screen.
Okay, that's done.
Make it a slideshow, Dr. Poonam.
Yes. Is it okay?
Yeah.
Okay.
Yes.
So, good evening, everyone. I must congratulate Team FOGSI and JOGI for this innovative initiative, and thanks to team members for selecting our research paper for this web series. The research article topic was, it was a prospective study to determine the predictive ability of SDP gestosis score for the development of preeclampsia. This is the first page of our published article. Now, SDP spectrum that you all know, it ranges from very mild disease, that is just an elevated minimal clinical significance, to another extreme, it is a severe hypertension with multi-organ dysfunction or end organ damage. Worldwide incidence is around 5 to 8% of all pregnant women. And as an Indian study, the overall pooled prevalence of preeclampsia in India was 11%. According to the National Eclampsia Registry and FOGSI ICOG, the incidence of preeclampsia is increasing. Prevalence is 9 to 10%, and maternal mortality attributed to this eclampsia is 4 to 6%. But why it is increasing? Increasing prevalence because of increasing prevalence of cardiometabolic diseases in women of childbearing age group, advanced maternal age, gestational diabetes, lifestyle modifications, obesity, excess weight gain during pregnancy. And preeclampsia is a major cause of mortality, morbidity worldwide. Various complications in mother is abruption, DIC, pulmonary edema, ARF, heart rhythm disturbances, and deadly effect on various organs like liver, brain, and lung. And in fetus, fetal growth retardation, preterm deliveries, and eventually fetal death. The key word is prediction and prevention. How will we predict and how will we prevent this deadly condition? Prediction. When we add prevention in the prediction, then definitely we decrease the incidence of preeclampsia. So the early diagnosis is essential, but there is no universal recommendation to detect it early. And it is not a single effective screening test available till date to be used by one and all. There are various existing tests that are invasive procedure or ultrasound guided that can only be done by expert physicians and medical officers. They cannot be administered by grassroots level healthcare provider. And our Indian population, 70% lives in the rural communities and they seek their primary health advice at the PSCs or CSCs. So we need some type of test that can be used easily by our grassroots level healthcare provider, so they can easily predict PIH early and refer that patient to us. So now the answer is yes. That is a simple risk model that is with the name of SDP Justice score. It is devised by Dr. Godak Mandrukar, and further modifications was done by committee including Dr. Sanjay Gupta, Dr. Suchandra Pandit, Dr. Alpesh Gandhi, and Dr. Girja Wagh for effective screening of preeclampsia, and it is endorsed by our society FOGSI. A careful history early in the first trimester can predict mothers at risk, and this can be done by any healthcare worker by using this SDP Justice score. It has very advantages like nil cost. I can say nil cost alternative to other tests. It is highly cost effective as compared to existing screening tests. Simple to use. It is history based mainly, blood pressure, thyroid status, sugar status. During initial assessment of all the antenatal women, it predicts the risk of the pregnancy-induced hypertension. Scores is when ranging from 1 to 14, it is given for mild symptoms, and each item has score 1. And item from 15 to 20 are classified as having moderate PIH symptom, and each item has score 2. And number 21 to 27 are classified as severe PIH symptom, and each item receive a score 3. And when the total score is equal to or more than 3, pregnant women should be marked as at risk for preeclampsia. The factors that has score 1 are either the age is less than 19 or more than 35, maternal anemia, BMI more than 30, primary gravida, short duration of sperm exposure, woman born as small for gestational age, family history of cardiovascular disease, polycystic ovarian syndrome, interpregnancy interval more than 7, conceived with assisted reproductive techniques, mean arterial pressure more than 85 mmHg, chronic vascular disease or dyslipidemia, excessive weight gain during pregnancy. All these factors has given score 1. Then the moderate risk factors which assign score 2 are maternal hypothyroidism, family history of preeclampsia, gestational diabetes mellitus, obesity that is BMI more than 35, multifetal pregnancy, hypertensive diseases during previous pregnancy. These are the moderate risk factor, and now come to the severe risk factor, and score 3 is assigned to even a single score. That means even if a single factor is present, the score is directly go to the 3, and woman is labeled at the risk of developing PIH. That these are the pregestational diabetes mellitus, chronic hypertension, mental disorder, inherited or acquired thrombophilia, maternal chronic kidney disease, autoimmune disease like SLE, Eplaz and rheumatoid arthritis, pregnancy with assisted reproduction, especially with the ovum donation or surrogacy treatment. So we have done this study with the aim to assess the sensitivity and specificity to predict the preeclampsia based on the justosis score in first trimester. It's a prospective cohort study in a hospital setting. We have included around 473 pregnant women presenting in first trimester from October 22 to 21. We excluded if the woman already on any hypertensive treatment, pregnant patient with COVID-19 disease, malignancy, liver disease, intake of alcohol or substance abuse or smoking. Main outcome measure was diagnosis of preeclampsia or eclampsia. Written consent, institutional ethical clearance was obtained from all, and detailed demographic history was taken, age, gravida, obstetric history, menstrual cycle regularity, PCOS history, marriage, parity, past medical surgical intervention, previous present medication were taken, BMI, blood tests for the thyroid profile, blood sugar profile, and careful history and blood pressure was recorded. Then process of risk scoring was done. This score involved all the existing and emerging risk factor in the pregnant woman. Score 1, 2, 3 is allotted to each clinical risk factor as per its severity in development of preeclampsia. With careful history and assessment of women, a total score is obtained. And if the total score is equal to more than 3, the woman is marked as at risk for preeclampsia. Finally, this is the flow chart. Finally, we have included 473 women after excluding these few patients, and the result, that means how many patients, results of the diastosis score. In 473 women, the diastosis score was 1 in around 200 patients, that is 42%. And it is diastosis score 2 was found in 204 participants, that is 43%. And diastosis score was 3 was allotted in 69 patients, that is 14%. The pie graph is clearly demonstrating this. And these are the patients who developed preeclampsia. Around 71 women developed preeclampsia. And out of 71, 59 were correctly predicted by SDP diastosis score more than 3. The remaining 12 cases of preeclampsia, 8 patients had diastosis score 2 and 4 patients had diastosis score 1. Then the sensitivity is specific positive predictive value and negative predictive value analysis. If the diastosis score is more than 3, the sensitivity is 83% and specificity is 97.5 and diagnostic accuracy is 95.35%. For the diastosis score 2, sensitivity is 94%, but the specificity is drastically diagnostic accuracy is 55%. So diastosis score 3 has better sensitivity and specificity for predicting the preeclampsia. These are the other biochemical markers for screening tests that are available, that is vascular endothelial growth factor, soluble FMS-like tyrokinase, placental growth factor, soluble endoglen, glycosylated fibronectin. But above these markers in combination to this diastosis score definitely increases the predictive value, but then it is not very cost effective for our population and cannot be implemented at grassroots level. Then another study regarding prediction of preeclampsia at the early gestation, that is the waist circumference measurement for prediction of preeclampsia, a population-based cohort study in which 5,827 women were included and around 4,696 patients were analyzed. And they have concluded that waist circumference is a simple and inexpensive and reliable tool. First trimester antenatal visit allowing for risk prediction in the first trimester. It is performed in early pregnancy, mean 9 gestational weeks, all measurement before 15 weeks. The size of the uterus could not be at that time, size of the uterus could not significantly influences the waist circumference of the woman. These are some other high-risk factors, that is the prior history of preeclampsia, chronic hypertension, pre-existing type 1 or type 2 diabetes mellitus, renal disease, various types of autoimmune diseases. These are the moderate risk factors that are given score 2, and these are the various other associations that have indicated high risk and moderate risk factor for development of the preeclampsia. According to the NICE, these are the factors for the high risk factor, that is previous pregnancy with preeclampsia, chronic hypertension, autoimmune disease, and they have given also moderate risk factor. ACOG has already defined the high risk factor and moderate risk factor, as well as ISSHPs have also given their moderate and high risk factor. What's new in the screening for prediction of PIH? The mean uterine PI that may be more than 95 percentile. Another emerging tool is spectral Doppler for maternal internal carotid and distal anterior circulation may be demonstrated. That is decreased RI and PI in ophthalmic artery with higher peak and diastolic velocity. And another ophthalmic artery RI, if it is less than 0.72, that is high risk for maternal and fetal complication. And I would probably say this study is also going on in our college, that is SN Medical College, Agra. Maybe in further 2-3 years, we can present the data over this parameter. Another screening emerging test is decreasing PI and SD ratio in proximal cervical internal carotid artery. And another one is decreased PI and RI in the transcranial Doppler study of the maternal MCA and suggested cutoff as MCA RI is less than 0.5 and PI is less than 0.8. These are the another emerging tool. But all these markers require an expert sonologist to do. In a recent nested case control study, second trimester maternal serum cystatin C, C-reactive protein, uterine artery mean resistant index were observed to be independent predictors of preeclampsia, but all these tests need to be tested on the large randomized control trial basis. Or cohort study can be planned over these factors also. So what are the preventive strategies when we diagnose the woman at the early gestation to prevent the preeclampsia? So early diagnosis, timely intervention reduces the maternal and fetal morbidity and reduces the financial burden to achieve the national goal for all by 2030. Age of the woman, oral calcium supplements, folic acid supplementation, weight of the pregnant woman, body mass index, pre-existing disease, and aspirin. These are the few preventive strategies for prevention of the preeclampsia. Age, it is the most determinant. Avoid pregnancy at extremes of ages. Oral calcium supplement is the most important preventive strategy to be started from 14 weeks onward, 1000 milligram in divided doses, mainly to women with nutritional deficiency or in low middle income countries. A proposed mechanism is that hypocalcemia may stimulate parathyroid hormone or renin release, which may increase intracellular calcium in vascular smooth muscles, resulting in vasoconstriction and lead to higher blood pressure. So calcium supplementation may reduce the parathyroid release, thereby reducing the intracellular calcium and smooth muscle contractility, reduces the uterine smooth muscle contractility, and potentially improve uteroplacental blood flow, preventing preterm labor and delivery. We should avoid excessive weight gain in the pregnancy, and weight gain should be according to the pre-existing body mass index. Excessive weight gain is the earliest indicator of preeclampsia, and ideal BMI at the time of conception of the pregnancy should be tried. Then the recommendation over the aspirin is definitely strong. There are the various association, ACOG, NICE, FIGO have stated that the low doses of aspirin should be started at around 12 weeks of gestation. Some say 75 to 81 or 150. There are the various doses by different association, and some says it is to be continued till term. Initially, it was at 32 weeks, but now it can be safely given up to the at least 36 weeks of the pregnancy. Another novel drug is pravastatin. It is proposed mechanism of this drug is it is benefit because it causes reversal of angiogenic imbalance, it improvement of the endothelial function and prevention of injury from oxidation and inflammation. The statins which stimulate hydroxide 1 expression and inhibit the serum FLT1 release could have the potential to decrease the early onset preeclampsia. But this is under trial and it needs further evaluation. Metformin, preliminary data from RCT of metformin for the prevention of large for gestational age fetuses in obese women without diabetes are promising, although the primary outcome of reduction in neonatal birth weight was negative. with the metformin, and it is associated with 76% reduction in the preeclampsia with odds ratio 0.24. Further study definitely needed over this drug. Other treatments such as antioxidant treatment by vitamin C, E, oligoelements, and nitric oxide have no proven efficacy. So we have calcium and aspirin in our bag for prevention, and definitely the lifestyle modification, weight control during pregnancy for the as a preventive strategy. So the take-home message is SDP is the most common medical problem in pregnancy, and it affects the health of mother and baby. SDP risk is predictable with the help of SDP gestosis score. Proper and regular antenatal visits are must to detect it timely. So the use of gestosis app that is used by the grassroots level worker, there is no added cost. Free app can be used one and all. Identify the high-risk pregnancy in initial days. Clinician to plan and provide systematic care in these high-risk patients to prevent eclampsia and other complications by adopting the standardized clinical management protocol as must. So that no mother should die because of PIH or eclampsia. Thank you.
Yeah, congratulations. And I think that is one of the most important studies which has a great utility value for us in India, especially as you have said, in 70% of the population which lives in rural areas, and eclampsia, preeclampsia is one of the most still major cause of morbidity and mortality. We're able to prevent eclampsia or treat eclampsia early, but we are not able to still prevent preeclampsia, though we know that aspirin and calcium are there, such simple things to do. And also that ultrasound and the markers are not much available, though we have a very established and proven prediction modules either by FIGO or ISUOG or Fetal Medicine Foundation, the calculators and all. So I was really very much interested in this gestosis score validation, Dr. Poonam, first of all. Then a few queries that I had personally, because we were thinking of using this gestosis score, but did have some queries. So this is applied only at the first trimester, first visit, or did you kind of give the score again and again after the first trimester?
Ma'am, in this study, we have applied in only the first trimester, but in routine practice, we apply in second and third trimester also. Cooking, I think that center at which I am working, it is a tertiary care center, and it has a lot of peripheral draining areas, and much of the population take initial first 3-4 months care only there. Nearby setups like PSCs or CSCs, they used to come very late, around after 20 weeks. So we apply in those population also, still applying those population also. But in this study, we have just restricted it to first trimester just to validate it for the first trimester screening tool.
So again, my query is the same, because we have PHCs, CHCs, and they come to us in either after second trimester or in the early trimester, by which time the period is gone. And also the guideline gestosis score, we know that it has to be applied every time at every visit.
It is to be applied. Yeah. But we have
validated.
So in this study, we have validated for first trimester, but it can be used any time.
You had patients in the first trimester regularly coming to you?
Relatively less, but more we have in second and third trimester. And we used to apply this gestosis score in those patients.
First trimester. So that is the first thing. And second thing is, in the score, we have a short history of cohabitation. So mostly it's a history-based gestosis score.
Short history-based only.
Yeah, short history of cohabitation. How much period you have taken it as a short history while you were asking?
6 months. 6 months. 6 months, or only infrequent, when they have infrequent contact.
GDM screening also was done in the first trimester in this study.
Yes.
Yeah.
GDM thyroid screening is done.
When I have gone through the paper, I have observed that you have done the profile for autoimmune diseases, all the antinuclear antibodies for the rheumatoid factor. Did you do the investigations?
Rheumatoid factor we have not done, but we have done APLA in these patients just for the research purpose.
Just for the research purpose. That's what
Yes.
I wanted to clarify,
Yeah,
because
just
it's
for the
history
research
based,
purpose,
we are
and
going to
actually
ask about autoimmune disorders, but
Yes.
not only for the research purpose.
only for the research
Uh,
purpose. And
A few queries that I had. Ma'am, Sujata Madam and Alka Madam. Thank you so much.
No.
Thank you.
Whatever you asked, I think that made sense.
And
Okay.
one more wonderful, actually, this is what the PHCs, if only the PHCs and CHCs can apply this gestosis score with little bit of training, and that is where really it matters.
Yes,
And
definitely.
Madam, I just as I was going through her presentation, Dr. Poonam's, they have wonderfully validated it in their population, and really they have given us the importance of about score 3, how it really picks up as good sensitivity. That's very good news for us. But do we have to validate it against the FMF or ISWAG kind of thing, Madam, just for us as an additional research?
Dr. Poonam, it was an excellent paper, and this is a need of the hour because this is the second PIH, pregnancy-induced hypertension is the second most common cause of the maternal mortality. And if we can predict, we can prevent, definitely we can reduce the maternal mortality and morbidity. As Dr. Kiranma has said, that you did SLE, apply RA, autoimmune disease, for the academic purpose. Now, one more question is there, that if the thyroid function TSH is normal, then still do anti-TPO antibody?
No, if it is normal, we routinely not
Not do.
Not
But for this paper, have you done something sort of
Yes,
that?
just for the academic
Yes.
purpose. We
Yeah.
have sanctioned it free of cost from our college. Then
So you have done all this investigation, because basically when you say your paper is for the grassroots level, health professional, then thyroid function we do, right? But as
but
far as this,
anti-TPOs apply will not be work.
yes, we don't do
out
unless the patient has some previous history of recurrent
previous history,
abortion or
loss.
something
Yes,
SLE
definitely.
history, then only we go ahead with that. So this is a good score, but I'm very impressed that if she's a priming gravida, age is more than 35, and she's of short duration, of woman born was small gestation age, all these factors can really definitely give us the idea of the predicting and prevention. Now I have a question. We start the calcium for all the patients from 13 weeks, 12
From
weeks,
12
weeks onwards, right? So if we are going to give as a preventive aspect 1000 milligram, otherwise also we give 1000 milligram. So is it going to add, is your aspirin is going to add the advantage is calcium and aspirin? Are they having added advantage or they are not having advantage? Because calcium we are giving to everybody, but we have to
In
give.
my personal opinion, ma'am, aspirin is working as preventive measure for the preeclampsia. Calcium, as we are giving routinely, and it is in the literature. Some studies say that 2 grams is required for the preventive dose of the preeclampsia. Most of the literature is saying that 2 grams is needed.
Yes.
Some say 15 grams. There are various studies on different doses, actually.
Depending on the
Is that necessary to combine both this if I'm giving 2 grams per day calcium? So do you think that we should also suggest them to take aspirin?
Yes, ma'am. Aspirin is the major
75 milligram. I think it should be given to at least if there is any high risk factor.
So aspirin I will also prefer, definitely. But when we say preventive aspect, calcium supplement and the aspirin, so ideally you will say aspirin is the best. And calcium you can give as your required for the
We are
pregnancy.
routinely giving calcium.
I think it is both combined. Low dose aspirin and the high dose calcium. Both have the role in prevention of HDP gestosis.
So I would like to know from Dr. Poonam that since you have done this gestational score, you have given for the calcium also and you have given aspirin also, and your gestation score was more than 3. How many people had a PIH and they did not have at all?
In my study, there is around out of 71 that has developed PIH, 59 was from the 3 score group. And rest are from the 2 and even mild. One score group has few patients that develop PIH later on.
So
which are
my,
being-
Ma'am,
my
ma'am, they
question
have
is
not
that
taken
my
the-
question is that Kiran Mai, my question is that you predicted that they were having gestational score more than 3. So you started with aspirin and calcium. Could you prevent in them? That's what my question is. PIH. Are you getting my question? Could you prevent PIH by giving them calcium and aspirin with gestational score?
Some patient maybe definitely prevent, but all
Okay, so the study itself says that 71 were there with high testosterone score
70,
and 59 had a PI.
59 has developed. Maybe what was the compliance of the drug? Maybe patient is taking or regularly or not regularly. That is a big factor.
So definitely the lifestyle modification is going to play a very, very important role in all the diseases, not only PIH, but whatever diseases
PCOS and all that.
going to have. So that is a very good message that at grassroots level, healthcare professional should do the testosterone score and reduce the, prevent the, PIH, or if it happens, they have to, deliver these babies as early as possible once they are matured. So this is a very good message. And, over to you, Chairperson.
Thank you, ma'am. Actually, it's a very, very useful kind of study for our setting. So we definitely can be confident and start using testosterone score and then give aspirin and calcium. I think this goes a long way in preventing preeclampsia. Dr. Sunil, you wanted to ask.
And it should be promoted.
Yes.
The ANMs and GNMs, they should be given training regarding this.
Yeah, the training part is one thing. A little bit difficulty would be about calculating the mean arterial pressure and the accurate elicitation of history, but it requires some training, but it is a must, I feel, considering the benefit that we get to prevent.
Sunil, before you go ahead, Dr. Geeta, our editor emeritus, is there. Dr. Geeta, would you like to say anything? If you are around, I can see her. Geeta? Because she is there online.
Yeah.
Okay, Sunil, you go ahead.
A very nice study, madam, and importantly, it is by our Indian clinicians for Indian population. FOGSI and even Justice's like committee and scientists should take it further, standardizing the protocols according to me. In fact, it can have like first trimester score development, followed by at one particular point second trimester also, because many of the risk factors are like grade 1 contains excessive weight gain during pregnancy, then development of GDM. So definitely it has got a good potential and we congratulate you, but it should go further by standardizing the protocols. So it will help our paramedical healthcare workers to develop such goals, including doctors also, even resident doctors.
Yeah, one final query, Dr. Poonam. Mental disorders is one of the points in the score. So how did you screen for the mental disorders? What mental disorders you had asked in the history, out of curiosity? Because
if the woman have some history of anxiety, or if she is on the medications for anxiety or other psychotic disorders, then it is categorized under these.
Thank you so much. Over to you.
Yeah. Over to you, Sunil.
Yeah.
Geeta is still there. Geeta, would you like to come in?
Geeta madam.
Madam is muted.
Geeta madam?
Okay. So both the presenter presented very well, and chairperson also did the excellent job, and the take home message is very good for the first paper as well as the second paper. And if we continue to do this way, the studies and telling our colleagues, we can definitely improve the maternal and perinatal outcome. So Sunil, vote of thanks and.
Yeah, thank you very much, all the chairpersons once again and the speakers. I would request Dr. Pradnya Supe, madam. for vote of thanks. Madam, are you there? Super Madam?
Yes, I'm there. Am I audible?
Yes, yes.
Yes. So I would like to thank, first of all, our EIC, Dr. Madhuri Patel, for having such a program, which is really so enlightening. Discussion of these articles which are published in a journal has actually opened our eyes to actually what work has gone to writing these articles and make us understand this article much more. I would like to thank our chairpersons for today, Dr. Sujata Darvi, Dr. Kiran Mai ma'am, and Dr. Alka Pandey, for their lovely questions and lovely things that they said about the articles. Our speakers for today, Dr. Vandana Bansal madam and Dr. Poonam Yadav madam, and also our MOCs, Dr. Sunil and Dr. Pradnya Changede. And lastly, but not the least, I would like to thank Maria Pereira, our JOGI office employee, for taking such an effort for smooth running of this program. So thank you so much, everyone, and thanks for joining this program.
Let me say, Maria, I must thank Maria. She is the one, she's asset to our journal. And, whatever work is there, she will do so nicely and, perfectly. So, Maria, thank you very much. And I must thank all the delegates also. Not only the presenter, chairperson, and, our chief guests and everybody, but our delegates who have joined and, were there because they have so many webinars. I can see Kanchan Sharma moving here and there. They have so many webinars and they could join over here. So I thank all of them also for this, program. Thank you, everybody, and looking forward to see you next month on 3rd Wednesday, 4 to 6 p.m.
Thank you, madam. This was excellent, really excellent to hear.
Thank you, madam, for the wonderful program and the opportunity.
Thank you.
Shall I end the meeting for all?